Welcome to Physicians Who Lead, the podcast where we sit down with physician leaders who are shaping the future of healthcare. Each episode, we dive into the real challenges facing our system today and hear directly from the physicians leading the way with innovation, resilience, and vision. If you want to understand how healthcare is changing and meet the leaders driving that change, you're in the right place.
Welcome to the Physicians Who Lead podcast. My name is Kevin Kirkpatrick. Today, my guest is Dr. Mark Olszyk, longstanding physician leader in the United States, edited and participated in a Chief Medical Officer's Guide book. So welcome to the podcast.
Hey, thank you very much. Really happy to be here, Kevin.
Yeah, no, I appreciate that. How I normally start these is just to give the audience a bit of a career breakdown and talk a bit about kind of where you started clinically and how you transitioned into leadership.
Okay, that's my cue. So I went to medical school in New York City, a place called Columbia University. And then I started postgraduate training with the Navy in San Diego. I did 1 year as an intern, and that was enough, apparently, to go out and take care of Marines. So I was with the 4th Marine Regiment in Okinawa for about a year. And that's where my leadership learning journey started. I think I made a lot of mistakes, learned a whole lot, kind of being independent on my own, supervising my own staff and supplies and getting mission ready. Did my best, but look back and I would have done some things differently, given 25 years of hindsight. After that, I came back to San Diego and finished my emergency medicine residency. And then my duty station was Great Lakes. So I was there for 3 years in charge of a very busy emergency department. And after a year in the private sector, the federal government called me back. They were going to combine the local VA hospital with the Navy hospital, kind of consolidate resources. And they asked if I would want to be the first inaugural chairman of emergency medicine. And at that time, they didn't know they had other emergency medicine docs throughout the VA. So I started up the emergency department. I hired the nurse director, hired all the staff, met with the engineers, suppliers, learned a lot about construction and staffing and hiring. And then I reached out across the nation and found that there was a community of Veterans Affairs emergency medicine docs. And I became the head of the national group. And after a few years there, made my way back to the East Coast where I grew up because my wife and I started having children, and took a job with a VA in Baltimore. Then went to DC for a year at the senior executive service level. And then I came back to the private sector. I've been at Carroll Hospital for 13 years as the chief medical officer at VPMA.
Excellent. So you obviously, you'd spent a lot of time at the bedside and stuff like that. How has that shaped you when it comes to leading other physicians?
Right. Yeah. So I definitely spent a lot of time at the bedside. So let me answer that with another question that will make no sense. And the question is math invented or discovered? So what are you talking about? So most basic math equation, right? 1 + 1 = 2. Makes sense. Take one orange, add another orange, you have 2 oranges. But are those 2 oranges ever really the same? There's probably some difference in appearance, weight, volume, etc. Same thing for kids. I got 4 kids. To say I have 4 kids makes it easier to figure out how many airplane seats I got to buy or insurance or taxes. But is one kid equal to another kid? Not at all. My son is not my daughter. My oldest is not my youngest. So there is no real equivalent. There is no one and another one. There is no patient and another patient. Everybody is individual. There are models, and all models are wrong. Some are useful. So when you say we want to have 95% of this, or we want to have an average length of stay of 7, we're assuming that everybody is alike. And that is helpful in some respects. But as a physician, every single patient is an N of 1. They're an individual. And when you go see a patient, you have to block out everything else. You're totally concentrated on them. You have to draw from your experience, and you have to draw from science and best practices, and they use models. But as a clinician, you always remember that you're treating individuals and families, and everyone has their own personal experience, and they bring their own way of thinking, their own expectations, and hopes and fears. So whenever you're making big decisions in a boardroom, you're not just moving around numbers. Numbers are fungible, dollars are fungible. People are not. People are individuals, and you always have to remember that.
One of the things I've noticed in the 20 years I've spent in healthcare is that change is it's not always an easy thing. And how do you build trust with physicians when, their potential is to push back on administrative decisions and stuff like that? Like, how do you bridge that gap?
Yeah, yeah. Well, the first thing is building trust. And how do you build trust? If you've seen Ted Lasso, he has a quote, always be curious, not judgmental. Curiosity just means you're willing to listen. So when you listen to people, when you make a habit of listening to them over and over, and you understand their stories, and you can joke, and you remember things about them as individuals, you begin to gain trust. And trust takes a long time to earn. It doesn't take very long at all to lose. So you
Hmm.
have to guard that. It's one of your most precious resources. So once you gain trust and you continue to earn that trust and maintain it, then you can help. Then you can explain some of the changes. And there's always changes, and changes are accelerating. You can be very candid, and you can be a straight shooter and say, "Listen, here's the situation. Here's what's going on." Now, you also have to remember that pushback isn't hostility. It's passion. When people push back, it's because they care. And if they didn't care, then you have to worry. So the trick is to translate no way into tell me more. So engage in those conversations. So listen first, reflect concerns back, and then work together, co-create a solution. Doctors don't always need pep talks. They need proof that the changes are there for a reason, to make care safer, to make it better, to increase a patient experience. Sometimes it's because you're conserving or marshaling scarce resources. And if you can bring them in, help them be part of the solution, help them advance some of the alternatives, then that resistance turns into ownership. And that is the rocket fuel for change.
You mean, so one of the things that somebody once talked to me about on this podcast, when moving from a physician role to a leadership role, was,
Mhm.
managing the different perspective of both resources and time. How do you support a physician that's moving into a leadership role to change the mindset where they're not, as you mentioned, focused on that one patient, but they're looking at things from a systematic lens?
Yeah, we see this. I see this every day. Providers, physicians, they want what's best for their patients, and they want the tools, not always the latest tools, but the ones they feel are necessary. They want a schedule that makes sense. They want adequate staffing, and those are all. There's different ways to assess what is adequate. So there's some leeway there. We would all like to have more of everything, but in reality, you can't have everything you want. So you just have to, again, bring them in to the discussions. So being a CMO is a little bit like uh, being a priest and an accountant. On one side, you hear the whispers, do the right thing. You always do the right thing. And on the other, can we afford it? So the art is refusing fake choices. So
Right.
we have to aim for the sweet spot where quality and stewardship coexist. And you have to bring in data, creativity, sometimes a little bit of stubbornness, to find the solutions that serve both the patient and the budget. I don't really like the term no money, no mission, but if the hospital is bankrupt, the patients lose too. So,
Yeah.
healthcare finance is incredibly complicated. It changes all the time. It gets harder all the time.
Yeah.
But we have to figure out how to balance, revenues and opportunities with expenditures, and costs continue to climb, and supply chain is a little bit uncertain given everything that happens, whether it's natural or artificial disasters.
Right.
So you have to do your best to anticipate that and then respond accordingly.
So, I mean, as the CMO, you interact with a lot of physicians on a day-to-day basis. How do you identify, the next leader? And
Hmm.
if you do identify them, what do you do to support that?
Well, sometimes it's pretty easy. You ask for a volunteer, and 50 people take one step back, and the one person that didn't looks around and says, "Oh, how did I get here?" Sometimes you can identify the people who are curious, who want to make a change. They have maybe a little glimmer in their eye. They're the ones who ask why instead of just what. So when you see that, you see they're interested. There's always opportunities for leadership. I've given leadership lectures, and people say, "Well, where can I get the opportunity?" they're all over the place. And it's not just in medicine. I was a Cub Master and a Scout Master for a long time. Every organization is just begging for people. School organizations, faith organizations, community. And those are great opportunities to learn and to lead because you might not have a uh, direct way to influence that person. They don't work for you. You can't. You're not giving them a paycheck. You're not giving them an annual evaluation. It's a voluntary basis. So you
Hmm.
have to really use your persuasion and your people skills, and it's just really excellent training for formal in hospital leadership. And then in the hospital, there's lots and lots of committees, and unfortunately, just in my tenure, I've seen a lot of the what we would call citizenship, hospital citizenship, begin to erode. Physicians don't show up in the numbers they used to for the medical staff meetings because maybe they're contracted, they do their 12 hours and they go home. Whereas a generation or two ago, many of the physicians lived in the community. Maybe their parents worked in the hospital. They feel personally invested. They might have been their own boss. They might have run their own practice. So they really wanted to come in and be part of the medical staff or the medical executive committee. Now, sometimes it takes a little bit of persuasion. So if someone is really interested in leadership, if they make that known, they're going to have a lot of opportunities. Whether it's bylaws, credentialing, quality, there's just tons, and there's a huge need for physician leadership out there.
How do you encourage and and kind of foster engagement with physicians? Because again, a lot of things that you just mentioned are trends that are happening with newer generations of physicians. But
Right.
how do we build that bridge between leadership and the clinical physicians?
I like that to use the word bridge. In the book I wrote, I think either in the preface or the foreword, I talk about the importance of bridge building. And again, when I was a scoutmaster, we had a bridging ceremony where the kids would cross over this little rickety makeshift bridge from being Cub Scouts to being Boy Scouts. And I said, you're leaving the den, you're graduating to the patrol. Before you had your moms and dads do all the planning and activities. Now you're going to be in charge of yourself. And I said, bridges are really important.
Hmm.
You look at stories, look at movies. If you like Lord of the Rings, you know that Gandalf was over that one bridge, and then he had a very there was an incredible battle, and he fell, and then literally got resurrected. If you look at Jimmy Stewart in It's a Wonderful Life, the big decision moment was when he was standing at that bridge. It's all over literature and history that the Pope himself, his real title is Pontifex Maximus, the maximum bridge builder. So as a CMO, part of the job is building bridges between the administration and the medical staff, between the hospital and the public, between the board of directors and the medical staff and administration. So you're constantly building bridges. What does that mean? You're encouraging communication coordination from both parties. So how do you draw in the physicians? You let them know, what is important to the board of directors. They're not just some people coming in and showing up for meetings and asking difficult questions just for fun. They're the ambassadors of the community, and they take the message back out to the community. So you have to explain to them why they're asking that. Why is the administration doing this or that? Likewise, you got to tell the administration this is what the medical staff is concerned about. You're beginning to do things that are concerning to them. So it's all just about, taking one email and forwarding to somebody else, CCing, just you can't over communicate, you can't over include. You do have to be judicious about when and where you send the emails and have the conversations, but you have to have an open door. I find the best place to learn about the medical staff and see what's going on is just going to the physician lounge and maybe just sitting there and half eavesdropping. You hear a lot of things. People are very honest when they're, talking amongst each other, eating some goldfish crackers and some chicken soup, and they kind of let their guard down a little bit. Um, you know, Listening in that informal environment is really helpful, and also
Yeah.
having some fun. If you can ever get out, do some extracurricular stuff. Sometimes we'll, go out to dinner as a medical executive committee or medical staff. We've gone to ball games or retreats. That's a little harder to come up with the money for now. It's a little hard because everyone's got a demanding schedule. Just associating outside of work, really, if it's done right, can pay massive, massive dividends. We had a retreat in Florida 7 years ago, we went to a course, Horty Springer, and people still talk about that. The things they learned, the friendships they made, the relationships that were fostered. So it's just always about being available, being humble, being curious, communicating, just listening.
On the topic of communication, I had a physician, uh, albeit in Canada. He coined the phrase a FIM, and I said, "Well, what's a FIM?" And he
Mhm.
goes, "Fake input meeting." And the context was that he felt that often physicians were invited and chiefs were invited to listen and then take the message back to the physicians, right? So how do you build a relationship to the point where as a CMO, you're not having FIM meetings, you're involved early enough in the process that the decision you're communicating is something that you were actually part of?
Yeah, I like that. I have a reputation for not really enjoying meetings, especially ones that run long. I think it's Jeff Bezos. He had a model. He has a model at Amazon. The first half an hour of the meeting was just reading some papers because no one really has the time to read in advance. So he had some dedicated time to read the briefs, and then the next part of the meeting was about discussing that. So a meeting should not really be there to cascade information. There's easier ways of doing that. Everyone has lots of demands on their time. And the medical staff know that, if I can have a meeting and it's done in 10 minutes, that's it. And most people enjoy that. I once had a physician, we had a 1 hour meeting. We covered everything in 15 minutes. And I said, this is great. We did everything really efficiently. And she said, no, I have an hour with you. I'm staying around for 45 more minutes. Great. But most people are happy to be absolved of, um, a meeting that's no longer serving its purpose. I
Yeah,
try not to schedule standing meetings with any large number of folks. I do have one-on-ones. I prefer them to be ad hoc, but you probably need somewhat of a cadence just to make sure you know what's going on. And I like doing those in dyads and triads. So I used to have one-on-ones with just the service level chiefs. Now I bring in their counterpart, nurse director, nurse executive. And that way everyone knows what's going on. And sometimes we cluster them. So we bring in anesthesia and surgery at the same time. And that just
right.
becomes really, really efficient because everyone sometimes will assume they know what's going on, but they hear something else, and we can resolve a lot in those really quick, focused meetings. Sometimes you do need to have a little bit of a formal meeting, medical executive committee. It's got a standing agenda, but we're constantly tweaking that, trying to make it more efficient, putting some things into a consent agenda that you can read in advance and just ask questions if needed. Otherwise, just approve or not approve.
Yeah,
And I think people really appreciate that. And then if you can make meetings fun, we have a lot of diversity in our medical staff. It's probably the most diverse body in the area. And the same thing for a medical executive committee. And I said, hey, why don't we all take turns bringing in dinner, and everyone did. So we had a Greek night, we had a Turkish night, we had a Russian, we had a Colombian, Peruvian, and that actually was super popular. So you just do things that are fun, that are engaging, that let people show off their individuality and shine, and not just have data sharing, cascading. Let's go through 2 hours of the latest report. You can read the report. Meetings should be for discussion and for decision making and for conversation if the time allows.
yeah. I think my takeaway when with what you've just said is, just having very intentional meetings,
Mhm.
right, and not a meeting for the sake of a meeting, right. And I think I was employed by 3 hospitals at various points in my career, which is probably why I work for myself now. Is, like you go to meetings and it was really just kind of somewhat of a cover your butt type of
Mhm.
thing. And it was a meeting for the sake of a meeting. And, that actually does more harm than anything else. Right. So the, um, the last question I have for you is a bit more of a big picture type of question, but what role do you think physicians should play in shaping the future of healthcare?
I think they should play a big role. I've read some literature. Can't remember the exact citations, but seems to suggest when physicians lead an organization, tricks tend to improve. I think that's going back to the first question you asked. Every physician knows that patients are individuals and what it takes really to do over and over and over again, consistently, habitually as an organization to drive improvement. So I think a lot of physicians would enjoy the opportunities to lead. Sometimes we think, physicians, they spend so much time on clinical care, they couldn't possibly, understand finance or strategic thinking. But I think that some of them certainly do. Some of us have MBAs, some of us own our own businesses, so we do understand that. But more importantly, I think we know how to operate as members of a team, and we would certainly surround ourselves with people who are smarter than we are in the areas that we might not be as familiar with. We go through a lot of training. And some of it can be quite difficult when you're running codes, when you're explaining to a family that you're expecting a bad outcome, you're breaking bad news. But we're there for people's happiest moments and some of their worst, their saddest. We're there when they're giving birth or being born, or being revived from a heart attack or a stroke or getting a new hip or a new knee or walking again. And we're also there when they're in pain or in crisis. And I think those lessons never leave you. And I think that that changes you. It changes you as a person and as a leader. And those lessons and those stories become part of who you are. So I think that can only make you a better leader.
Awesome. So I have another question
Okay.
that I want. I probably have about 30 more, but I don't want a
Right.
5-hour podcast. Is there been somebody in your career that has been a great mentor or left a great impression on you?
That's a good question. There's been so many people. I think there's a saying in the East, when the student is ready, the teacher will come along. So I've had a number of mentors, great teachers in medical school, in the Navy. I think he was a department head, so he led, the emergency department. Very kind man. He was very thoughtful. He would, give you the shirt off of his back. He always asked how you were doing, no matter who you were, not just the resident physicians, but the corpsman, the guy pushing the broom. He would do anything for anybody. He was a great clinician. Just had an incredible attitude. He went on to become a 3-star admiral. So obviously, I'm not the only one that was impressed with him. But then later on, I had a series of bosses who I learned a lot from. Sometimes you learn from people who make mistakes, and you learn not to make those mistakes. I say it's great to learn from mistakes. It's better if you learn from someone else's. It's part of the reason why I wrote the book, learn from some of mine and some of the authors. And now, some of the people who really have an effect on me are the podcasters, people who are producing some of the content and material that's seems ubiquitous, but there's just some incredible lessons out there. There's great production value. They're distilled. And there's just so much to learn. So if you have a question or a concern, I'm sure you can find the answer or multiple answers, right out there. So I think you're probably now one of my mentors because of the podcast.
I hope for better for you, man. It's interesting. Like, there's so much potential for physicians in leadership roles. And I think that, strong organizations will embrace physician leaders as fast and as frequently as possible. And
Mhm.
if I look at the organizations that have had the most success hiring, they've got the best engagement with their physicians and they're developing a lot of leaders within the organization. And some organizations are just behind the times where they're not building the leaders themselves. And that's okay too, because sometimes finding a new leader helps you start building them too. So, it's a good endeavor for people. And, as like you said earlier, the organizations that are led by physicians and have stronger physician leadership, surprisingly, everybody expects them to clinically and like have a higher clinical score and effectiveness, which they do. But the thing that I think caught me off guard when I saw that statistic first is they also have the best financial
Mhm.
performance, right? So, the comment you made about, physicians being perceived as not understanding the financial stuff, I honestly, with investment in themselves, they can cover off those things with enough content to lead. I definitely think well, and I'm banking my business on improving physician leadership and facilitating more. So I appreciate you taking the time today.
Oh, yeah.
I think I shared a copy of a list of books in my LinkedIn group that I aim to
Oh,
include,
great.
because I do think people need to learn from each other.
Mhm.
Hence why I created that group, and it's an evolvement of my Facebook group, because LinkedIn seems to be a better platform. So I appreciate you taking the time to talk to me, and I'll continue to bother you going forward.
Sounds good. It's been a real pleasure. Thank you for having me.
All right, have a great day.
Okay.